Thank all of you for being here, and especially I want to welcome all of you, and particularly you first-time attendees to state leadership. We're just getting razzed up now, and I can guarantee you that by the time Monday night rolls around, you're going to be exhausted, but still energized and ready for those Hill visits. This year, our conference theme is creating roadmaps for practice. It's the second year in a row, for those of you who are returning, that you've known we focused on healthcare reform and its implementation. I alluded to this theme last year during my keynote when I said that we're facing uncharted territory with healthcare reform, and there's no real universal roadmap to guide us. The way the Affordable Care Act is unfolding reminds us that there's no single advocacy strategy for psychology that can address the diverse legislative, regulatory, and marketplace challenges and environments that we see from state to state. Some states have embraced the Medicaid expansion, others resist it. Pennsylvania recently submitted a Medicaid waiver to implement the expansion in January, while the Virginia Legislature, where are you from Virginia, has gone back and forth, can't seem to make up their mind whether they want to do the Medicaid expansion or not. So the landscape continues to take shape. Speaking of landscape, you all know as well as I that the terrain for professional psychology and other healthcare providers has been pretty rocky in recent years. Disruptions and demands on your practice have raised anxiety levels, and we appreciate that and understand it. Our members had to acclimate to new psychotherapy codes in 2013, and last year you faced compliance issues with HIPAA, with the final rule, and we were able to help develop some resources to help you with that. The profession has had to battle adverse decisions about reimbursement for our services and confronted situations where access to care has been unfairly denied. And we've experienced threats to our scope of practice related to psychological testing and applied behavior analysis and the behavior analysts. Meanwhile, our country doesn't pay near enough attention to mental health and substance use treatment. We've carved out this treatment for so many years and made people jump through hoops to get the services that they need, and that's patently unfair. And mental health care is chronically underfunded in this country as well. Do you know that 20% of Americans will experience a mental health problem in the course of a calendar year, as compared with, although a horrendous disease, a 6% incidence of cancer in adults in their lifetime? Yet in 2012, our federal government gave more than $5 billion to the National Cancer Institute, but gave only $1.5 billion to the National Institute of Mental Health. What's wrong with that picture? And we spend less than 6% of all of the healthcare dollars in this country on mental health and substance use disorders. And while we've certainly made some progress where mental health care is concerned, stigma continues to be a horrendous issue for those who need help. The challenges in our healthcare system have been compounded by difficulties with implementation of the Affordable Care Act. It's no news flash that the rollout of the Affordable Care Act has been pretty chaotic. Major deadlines, such as those related to the expansion of the employer mandate, have been delayed. There's been widespread concern about getting a sufficient number of health plans into the health insurance exchange. And with 2/3 of states opting out of doing their own exchanges and using federally facilitated exchanges, that was certainly compromised the healthcare.gov website when it rolled out back last October. But healthcare reform and implementation continues to be a work in progress. And there are hopeful signs, especially related to the goal of increasing the number of Americans who have health insurance in this country. As a result of the Affordable Care Act, between 4.5 and 5.5 million individuals opted for insurance plans through the new health insurance exchange or were included in the Medicaid expansion in the first 4 months of enrollment. Keep in mind, too, that all enrollees in these new health plans will benefit from our years of work to implement mental health parity because it's required in the Affordable Care Act plans. As we confront serious problems and confront the uncertainty of a healthcare system in flux, psychology continues to demonstrate that we are poised to help you with those challenges. For example, your practice organization has been actively engaged in advocacy around applied behavior analysis. Armed with a 2012 board statement and policy on behavior analysis and behavior analyst, we engaged a broad range of stakeholders in these issues. And I'm happy to say that in the last 2 years, there's not been a single state law implemented that restricted psychologist practice in the area of applied behavior analysis. Meanwhile, the neuropsychology community has had good success with a new advocacy model that I'm going to tell you more about a little bit later. By now, many psychologists know that we scored a major win regarding the Medicare 2014 payment schedule. In essence, we reversed the downward payment trajectory for psychological services. This happened despite the fact that we really expected that we might once again experience devastating cuts to our reimbursement for our psychotherapy codes. So it's worth spending a few minutes to tell you the story that led to a fortuitous turn of events. Long, long ago, back in 2007, the Centers for Medicare and Medicaid Services, or CMS, instituted a new process to calculate the practice expense portion of the Medicare payment. Those adjustments resulted in payment reductions that you all experienced every year from 2007 through 2013. In 2009, APA practice took the lead in convincing CMS that our psychotherapy codes were undervalued, i.e. we were seeing sicker patients, and a green light from CMS started a psychotherapy code revision process and analysis known as the 5-year review. That review is integrally connected to the work done by the AMA committee, specifically the CPT committee, and the Resource-Based Relative Value Update Committee, otherwise known as the RUC. So when you hear people talk about the CPT and RUC, that's who we're talking about. APA and the practice organization has been involved for many years in this work and on behalf of the profession, and we have been very nicely and amply represented by Drs. Jim Georgialakis and Dr. Neil Pliskin. As the AMA process progressed, we created an internal advisory group by tapping 7 of our APA divisions for real content experts about psychotherapy. Dr. Lynn Bufka, head of our Practice Research and Policy Office, contributed considerable content expertise to this process. In addition, Dr. Nan Klein from Utah represented psychology on the AMA CPT Psychotherapy Codes Workgroup. The multi-year process was supported throughout by our practice organization government relations staff, including Doug Walter and Diane Padula. And Dr. Randy Phelps was integral to that process and continues to focus on the AMA CPT and RUC as head of the new Office of Healthcare Financing in our APA Center for Psychology and Health. Many psychologists, some of you, participated in the survey process that we did here at State Leadership in 2012. That year, and again in 2013, we had hundreds of visits on the Hill during State Leadership with members of Congress whom you, as you will again this year, called upon to revamp a Medicare payment formula that is still unpatently unfair to psychologists. The AMA RUC, though, used the survey data from our psychologists and other mental health providers to determine recommended work values for what we do. And the upshot for psychology was favorable. RUC actually recommended to CMS higher work values for the new psychotherapy codes. But that's not the end of the story. Work values are just one component of Medicare payment, and the problem with practice expense still persisted. So we took our case directly to the top of CMS. Last summer, in meetings with CMS Deputy Administrator Jonathan Blum, our government relations staff emphasized 2 major points. One was that CMS changed, in the way in which they changed the practice expense, resulted in an untenable 24% decrease in psychotherapy Medicare payments between 2007 and 2013. And secondly, the reduction in the Medicare fee schedule adversely impacted the access of Medicare beneficiaries to our services. Fortunately, CMS seemed to resonate with those concerns. Meanwhile, our allies on Capitol Hill advanced our cause as well. Senator Patty Murray from Washington State herself contacted Mr. Blum at CMS to let him know of her concerns about what was happening to payments for psychologists. So 2 things happened by the time CMS released the 2014 Medicare fee schedule last November. One, the agency accepted the RUC recommendations for higher psychotherapy work values in a budget environment in Washington where we know there is horrendous, tremendous pressure to push costs down and keep the budget under better control. But CMS also adjusted the practice expense calculations, so the increases in our psychotherapy work values were not drastically offset by payment by the the practice expense calculation as we had anticipated. Yes, some of the codes that psychologists bill did see decreases in their value, but most of the codes experienced an increase, several of them sizable. And the real news is that the Medicare fee schedule in 2014 marked the first time since 2007 that the payment pool allocated for Medicare psychological services actually increased. The overall 8% jump meant, and this I think is very important, that psychologists had the second highest increase in payment allocation across all Medicare providers in 2014. Several factors contributed to this outcome. Certainly one was building relationships with the folks at CMS. We enlisted allies in Congress and had the help of people like Senator Patty Murray. We had good representation in the AMA committee process from our people who represent us. And we engaged grassroots psychologists in survey participation and in Hill visits like we'll do again this year. None of these factors alone could have produced the result that we got. But I can say confidently that if your practice organization had not played a central role, I wouldn't be talking about this at all today. I'd have found something else to talk about at this keynote address. And consider the impact that this has, that the payment changes have beyond Medicare, because we all know that the other carriers very often peg their reimbursement rates to what happens at Medicare. So I hope you'll think of this story the next time one of your colleagues back home asks you, what has the practice organization done for me lately? As much as I consider this a crowning achievement, again, let's remember that there's no single advocacy strategy that will support psychology's future as the healthcare system evolves. The same is true for practitioners faced with mapping out plans for their own practice in the years ahead. It's like using a road map. Some travelers take the interstate, some of you like the back roads. Many switch to alternate routes when they experience roadblocks. Similarly, practitioners may consider multiple paths in arriving at their future practice course. Viable practice options will vary from one practitioner to another. Some psychologists will be able to continue practicing like they do now, especially if they're well-established or late career. In many cases, this involves specialty mental health, and as I said, there is no shortage of need for specialty mental health services in this country. Developing a specialized niche practice provides a roadmap for some other psychologists. Other practitioners will head in a different direction, driven by the push towards integration as embodied in the Affordable Care Act and the reforms that are accompanying it. A combination of professional, marketplace, legislative, and regulatory developments are encouraging more collaborative, multidisciplinary practice models. As the landscape shifts towards more integrated care, new reimbursement mechanisms for sure are and will be emerging. And the demand for evidence-based practices, use of quality outcomes, outcome measures and process measures, including behavioral health measures, will continue to grow, and you will continue to be confronted by payers for the demand for those kinds of things. And the increasing use of technology for electronic health record keeping and telepsychology service delivery will also continue to evolve. Many of our members seem attuned to this evolution. In a survey last fall, we asked practitioners what changes they thought they might see in their practice in the next 3 to 5 years. Nearly half of them said that they would use more technology for professional and practice purposes. And a third of them said that they would further diversify their practices and skill sets. That was particularly true for our early career respondents. Obviously, the ECPs get it. Again, there's no single optimal path forward for practitioners. Psychologists need to be realistic as they evaluate their practice options. whether practicing on your own, practicing in a group, practicing in a big health center. And you may find it helpful to consider questions like, where am I in my practice? Charlie Cooper, you've done great work in this area. Where am I in my practice? Am I early career? Am I mid-career? Am I late career? That's going to make a difference. Am I on solid financial footing? Can your practice sustain reasonable income over the next several years with your current practice model? Are you prepared to invest the time and resources to integrate more fully with other practice partners? What's your bargaining power in your community? Do you have a group that's cohesive and has strong leadership? With whom might you realistically think about partnering? Professional associations can also be way stations along that journey, guiding practitioners to help them anticipate and overcome roadblocks that you are definitely going to encounter. So I encourage you to attend our Sunday late afternoon plenary session and also consider a Monday afternoon follow-up workshop that's going to focus on these alternate practice models. The models that we're showcasing may seem sort of foreign and really daunting to some of you, but they are examples of how psychologists can change their practices without ceding autonomy to physicians, and they're doable models. Dr. Peter Oppenheimer of Rhode Island and Michael Goldberg of Massachusetts will present what they've been doing to facilitate referrals between behavioral health providers and primary care practices. Dr. Keith Baird of Illinois is going to share his experience in the creation of a management services organization. Some of the models I said are going to be difficult, maybe for some of you to wrap your heads around, but we're hoping that we're going to start giving you the skills that you need to be able to do these things and take these things back home. Our profession addresses the mental and behavioral health problems that are, as we all know, so very, very costly to individuals, to families, and to our society. And we play important roles beyond healthcare in educational settings, in the criminal justice system, and in the workplace. Widely ranging professional roles require varying skill sets, and they also demand very finely honed advocacy strategies. And these strategies have to continually be refined as the political and economic and marketplace circumstances change. Earlier, I told you the story of our advocacy win with the Medicare fee schedule. And now I want to highlight another advocacy initiative created by neuropsychologists on behalf of our profession. As you know, CMS is not the only player, and the physician fee schedule is not the only or sole factor in Medicare reimbursement. There's a considerable amount of policy making that goes on affecting reimbursement at the local coverage determination level by the regional MACs, or the Medicare Administrative Contractors. And with so much going on across the United States in the 9 MACs, it takes psychology advocates that are willing to watch like a hawk what the MACs are doing, because they do silly stuff with regard to psychological testing and other services. And that's exactly what's happening with a new advocacy model for psychology and neuropsychology dubbed 360-degree advocacy. Our own Dr. Karen Postal of Massachusetts chairs the group of neuropsychology advocates that's been producing results since shortly after the group, known as the Interorganizational Practice Committee, or IOPC, was launched in 2012. The IOPC created a structured method for coordinating national and state-level organizations and resources and best practices. Hence, the 360-degree advocacy model engages players at all levels, wherever those players are needed from. The IOPC brings together the chairs of the practice advocacy committees of APA Division 40, the Society for Clinical Neuropsychology, in addition to other national neuropsychological groups and representation from your APA practice organization. National content experts, together with state leaders and advocates, engage in very targeted advocacy strikes on adverse actions taken by individual MACs. Last year, the group succeeded in having First Coast Services, the MAC that covers Florida, Puerto Rico, and the Virgin Islands, change problematic language in a coverage determination. The latest win affects practitioners in 10 states. The National Governmental Services MAC made nearly every modification that the 360-degree advocacy team requested in a local determination for psychological and neuropsychological services. The letter asking for the changes included the signatures of the presidents and the executive directors of every state association involved. I'll highlight just a couple of changes the MAC made. Their final local coverage determination clarifies that when medically necessary, providers or psychologists may assess patients for depression on their way into a nursing home. And providers are allowed to bill for integrating emotional measures into neuropsychological testing. An informative article published just this last month in the Clinical Neuropsychologist describes this new advocacy initiative. The authors characterize it as a roadmap to coordinate local, regional, and national resources for high-impact, efficient advocacy. So it's appropriate in light of this year's State Leadership Conference theme. Clearly, it's a model that can be applied to advocacy around a number of professional psychology's issues. So I hope you will read the Clinical Neuropsychologist and become more familiar with that very successful advocacy model. And while I focus on advocacy, I can never reinforce enough the crucial role of our partnership with the states and the provinces and the territories. So much of what happens to practitioners and in psychological practice daily happens so very, very close to home. State psychological associations defend practice at its very basic roots. For example, aided by legislative grant funds from our Committee for the Advancement of Professional Practice, the Alabama Psychological Association successfully waged battle when organized medicine in that state tried to get the phrase diagnose and treat deleted from the Alabama practice scope of practice. If organized medicine had been successful in Alabama, every practicing psychologist in Alabama would have suffered adverse effects, whether they were in the VA, in the state hospital, in the public school system, in the university counseling centers, and those in independent practice. There are countless additional examples of CAP grant monies being put to good use. Some recent accomplishments relate to healthcare reform, such as in Kentucky. Historically, psychologists have been excluded among the categories of eligible providers in Medicaid in Kentucky. But on January 1st of this year, that all changed. Kentucky's Medicaid Behavioral Health Network was opened up to any licensed provider. So my hat's off to Kentucky. Where are you? Kentucky Psychological Association, for your effective advocacy that helped usher in this very important change. On Sunday, thanks to the Minnesota Psychological Association, we'll be recognizing State Senator Julie Rosen with the State Legislator of the Year Award. Senator Rosen was the chief author of a bill that provides Medicaid coverage for consultation by psychologists to primary care providers. It's now a law in Minnesota and represents a big step towards enhancing integration of primary care and psychological services. Go Minnesota. So you can see we need lean, mean advocacy machines to protect our seat at the table and move psychology forward as the healthcare marketplace evolves. Psychology is a learned profession, as Dr. DeLeon has been known to say, filled with smart, creative people like the ones in this room. And we achieve good and even excellent results when we get energized and commit ourselves to making positive things happen. I've attended the Division 42 Fast Forward Conference and seen creative practitioners with a really entrepreneurial spirit taking control over their practice futures, and they're building rewarding and diversified practices. And I've participated in 19 state-level healthcare reform summits since late 2011 and been impressed with the strong state leaders who are committed to safeguarding psychology's seat at the table in your states. So to all of you involved, I commend you for forging affiliations with state departments of mental health, with Medicaid officials, representatives of your health insurance exchanges, other professional associations, consumer groups, and all of those folks with whom you need to be collaborating to build the bridges we need to ensure the viability of psychological practice. These experiences fill me with a sense of optimism as I look down the road at our future. So let's all continue putting to good use all of our collective energy and enthusiasm for the profession that we all love. Our patients, our profession, and our future depend on leaders just like you. Thank you. We got our, I see a technical problem in the back. Because I want to take a moment of personal privilege to recognize some folks. Is up there? There we go. Okay. These psychologists have been particularly generous in their financial support of the APA Practice Organization through their contributions to our Practice Leadership Circle, an annual major donor fundraising campaign, and I'd like to recognize them now. I want to recognize the 2013 donors who are with us today, and so when I call your name, please stand up. I'd like to ask the audience to hold your applause until everyone has been recognized. There are 3 major donors with us today in the Practice Guardian category, and they are Dr. Bonnie Markham of New Jersey, Dr. Virginia Waters, also of New Jersey, and Dr. Karen Postal of Massachusetts. And there are 12 donors here today in our growing practice leadership category. They include Dr. Barry Anton from Washington State, Dr. Anita Auerbach from Virginia. You all need to be standing up. Dr. Louise Dowse from Ohio, Dr. Michael Goldberg from Massachusetts, Dr. Cy Gross from Minnesota, Dr. David Hill from Kansas, Dr. Josephine Johnson from Michigan, Dr. Jennifer Kelly from Georgia, Dr. Susan McDaniel from New York, Dr. Beth Rom-Reimer from Illinois, Dr. Sheila Schuster from Kentucky, and Dr. Bill Strickland from Virginia. So please help me give these people a round of applause.